I've got nothing.
So, good evening, once again, colleagues and senior colleagues. We are in day 5 of our CPD workshop, and we invite Dr. Okine to lead the presentation. Dr. Okine, over to you.
Thank you very much, Dr. Kwashi. Good evening to everyone. Good evening to the leadership of Gamls. And I am always grateful for this opportunity. Dr. Kwashi, today I have tried to relocate, so I hope we have a steady network. I think it's a general issue with my location. So kindly let me know if there are any hitches.
It is better. I pray we continue like this to the end.
Thank you very much. So today is day 5 of our training. And today we are talking about automated blood culture, culture of swabs and stool. All right, so the objectives is that at the close of this session, we should know how to collect blood culture properly for the test, how to process the blood culture itself, how to culture stool for enteropathogens, and how to culture the common swabs that we get in our laboratories. So yesterday we looked at the manual blood culture system, and today we are looking at automated blood culture system. Okay, so like we said yesterday, blood culture is when the blood of an individual who is suspected to have an infection is taken and put into a medium to support the growth of any possible bacteria or fungi present so that we can use it for diagnosis. And like we said yesterday, the main aims of blood culture is to confirm the presence of an infection, to identify the pathogen responsible for that, and to find the drugs that can help in treating them. And the indications for blood culture include undetermined fever above or equal to 38 degrees Celsius, when there is hypothermia, signs of sepsis such as chills, high heart rate, low blood pressure, rigor, or when there are some severe local infections, a physician can request for a blood culture. So these automated blood culture systems, they usually employ sensor technology with growth algorithm to give us our results. And we call it a continuous monitoring blood culture system. So what this does is, usually when you open this equipment, some of them you see that there's agitation. And like we learned far back in our secondary school, agitation can increase the reaction, the speed of a reaction. And so it is a bit advanced than the manual method because it can give us a shorter turnaround time. So you can set up your automated blood culture system to give out your results in 5 days, unlike the 7 days we saw in the manual system yesterday. So yesterday we spoke about how you have to come every day, bring out your culture bottle and look for evidence of growth. And we look for them with our eyes. Okay, so you're looking for turbidity, you're looking for flecks or bubbles on the surface or hemolysis. And there can be human error. Okay, so someone can have an eye issue, may not see the turbidity properly, or may not see the bubbles and may miss the evidence of growth. So these automated blood culture systems, they remove human errors involved in the manual blood culture, especially when it comes to checking for evidence of growth. And the vials, the bottles that are used for this automated blood culture system have ingredients that are able to neutralize any antibiotics given to the patient prior to sampling. Or for instance, in the anaerobic system, they have some detergents that are able to break red cells and break white cells so that any intracellular bacteria can come out and then be supported by the medium. So it is enhanced when it comes to growth compared to the manual. It is more flexible to work with. Just picture pulling this bottle out for 5 to 6 days, looking for evidence of growth. And for the automated, all you just have to do is make sure your machine is working properly, and you just wait for a beep for positive or a beep for negative, and you pull out your bottle. So it's very easy and flexible to work with. So there are several systems on the markets, and in Ghana, generally, we know of popularly of these 3 companies. So the Biomirror Back Alert is around in the country. Then the BD Bactech in various forms. They have various forms. And then quite recently, the Render is also popping up and then gradually spreading on the market. So these are the examples of automated blood culture systems that we can have. So they come with their specialized vials or blood culture bottles. So this we see here is for the Back Alert, this is for the BD, and this is for the Render. So they have several forms. They have anaerobic, like I spoke of. For the anaerobic, it has some lysine agents that will break the cells. So the anaerobic, the bacteria can be intracellular. So once the cells are broken, they can come out and be fed. We have some for pediatrics, we have some for adults. They are different. So every manufacturer and their specifications. So we have all these at our disposal. So how does this system works? I'll talk of the most popular one, the BD, Bactec. So the bacteria grows. Once there's bacteria growing in a medium, it releases carbon dioxide by metabolizing the substrates in the medium. Now there's a dye in the sensor at the bottom of the medium, which reacts to the CO2 that is produced. And this regulates the amount of light that is absorbed from the bottle. And this is read by a photosense. And then we can get our positive or our negative results from this simple but effective protocol. Now, to work on blood culture, we have talked about equipment a lot. So we know the major ones, the microscope, incubator, but for the automated blood culture systems, you need to have the automated system, whichever panel you are using. If you're using the render or the BD or the biomirror, you need to have that. And then their respective bottles, because most of these equipment come with barcode that you have to scan. So you need to get the bottle specific for the machine you have. You need your primary plates, BAC, McConkey, SDA. You need media to help you in identification. You need your antibiotics, saline, plasma. You need your stains, very important. You need miscellaneous pasta pipettes, lights, cover slips, all those things to help in the testing. All right. So how is sample collected? The blood sample should be collected by a trained personnel who has the competence of collecting blood culture samples. So you can have a trained phlebotomist, a laboratory scientist, medical doctors or nurses who are all trained and have the competence for doing that process can do it. Now, for the automated system, talking particularly about the Bactec for the pediatrics, 1 to 3 mils of blood is required. And for the adults, up to 10 mils, 8 to 10 mils of the blood is required for you to fill it. So it is said that when you have enough quantity of blood, it helps in recovering positivity rates, especially when you have sparse number of bacteria in the blood. Okay, so usually blood culture is supposed to be in people who are very sick. So most patients will be on the ward. It's just a few who are walk-ins. So you have to identify the patients, whichever way your hospital protocol says, you identify the patients, make sure you have all your things set up for the sampling, because a lot of needle sticks injury is as a result of not organizing yourself well. You start sampling and realize, I need to take this, I need to do that. So set everything up and then you wash your hands. And very importantly, you see that when you pick the Bactec bottle, there are graduations on the side. There are marks on the side. Now the vacuum in the Bactec container can take so much more than is required for the sampling. So it is ideal that you mark the fill mark where you want to fill your blood to. You mark it with a marker on the bottle, and then you clean the septum of the plastic part on top of the bottle, you clean it. And then you go ahead with your phlebotomy skills. Very important, like we said yesterday, you start with 70% alcohol, and then you go in with iodine, clean. And once you clean, don't go back to touch the venipuncture sites and allow to air dry. Don't blot dry with a cotton or swab. So once it is advisable to keep your Bactec bottle upright, because you are going to look at the volume on the fill mark. So you place your bottle upright, you put in your needle with the vacutainer, you go ahead and then dispense the blood to reach the fill mark. And then you come out, you label according to the hospital protocol. Now, when you are labeling, take notes not to cover the barcode portion on the bottle, because you have to scan it to have access to the automated system. And then you apply your cleaning, discard or dispose of your sharps appropriately, and then transport your sample immediately to the lab. So in case it is a needle, you don't have a bacteria and you're using a needle, after taking the sample, you go through the process we did yesterday, you change the needle before you insert it into the septum of the blood vial to discharge your content. Now let's look at this very carefully. So we said we have an anaerobic and aerobic blood culture system. And even though majority of the bacteria that causes bacteremia or septicemia are aerobic, we still go ahead and check for anaerobic. So when you want to dispense your blood, there are several ways of how to dispense your blood. If you are using what we call the butterfly or the winged collection, if you can see my cursor, if you are using the butterfly system, because of this long, fine tubing here, there is oxygen or there's air in it, okay? So if you go and insert this into the anaerobic medium first, you would have pushed air into the medium. So when you are using the winged or the butterfly blood collection sets, you go to the aerobic bottle first. You inoculate the aerobic bottle first. So after you push everything in to the fill mark, then you come out and then you bring in your anaerobic bottle. So it is assumed that by then blood will be filling the tubing. So there will be no introduction of oxygen or air into the anaerobic bottle. So for the wing culture bottle, for the wing blood collection sets, aerobic first before anaerobic. Now it is vice versa for the needle, because for the needle, the blood is already full. The top of the syringe rather has air. So you inoculate the anaerobic bottle first before you come to the aerobic bottle. Now, if in case you struggled with the blood collection, you couldn't get enough volume to do the 2 sets of bottles, it's advisable that you always inoculate the aerobic, since I said already, we know that most of the bacteremia causes are from aerobic or facultative bacteria. So this is something that most of us do wrong, and we have to take note of that. And so yesterday we were talking about whether we should take 1 set or 2 sets. So a set is when you take aerobic and aerobic. The second set is when you take another aerobic and aerobic, and it's advisable to take it between an interval of 1 to 2 hours. This will just help us to see whether there's continuous bacteremia in the system. So for the first set, you take it on 1 arm. It's advisable to take multiple sets, multiple sites sample, 1 arm, another arm. Whilst I was researching for this, I even came across a study that said there's no significant difference in taking a sample from multi-sites. But this is what CDC is saying. We take samples from multiple sites to inoculate our first and second sets. All right. And the multiple sampling also helps with identifying false positives. So if you have 4 bottles and the person is really sick, you should see all the 4 bottles or majority or at least 3 reacting, showing positive. But if you are seeing just 1 showing some commensal or something, you can rule out a false positive. So let's go to the process proper. So after the blood is collected, inoculated into the medium, quickly brought to the lab. And this one, we do not refrigerate. It can be at room temperature for up to 2 hours, but you don't have to refrigerate. Then you insert into your bottle, into your automated system, and you just wait for an alarm or alert of either positivity or negativity. So when you have a positive alert, you subculture some of the blood using a vacuum and the cup, or you can use a syringe, and that one is a bit more risky because you can end up getting a needle stick, but the vacuum with a cup is far more better. So you put a few drops of the well-mixed blood onto a slide, and then you gram, almighty gram, we do our gram, and then you inoculate onto blood agar, chocolate agar, and maconke agar. And then you incubate the blood agar and maconke in ambient air whilst the chocolate agar goes under in the canister, candle jar. And then your gram reaction can tell you whether it is a gram positive, gram negative, it is candida, it is clostridium, it is contaminant. So this information from the gram has to go to the physician as a preliminary report, especially if it is a possible pathogen, like you see gram-negative rods or gram-positive coca in clusters, in chains, or you see candida. You have to report this to the physician, no matter which day it came on, right? This system is closed and a bit more protected from contamination. So this picture I got is using the Malditor for identification. Several studies have come out that once it is positive here, instead of doing the culture, waiting another day for it to grow before you do identification, you can directly identify in the MALDI and even do sensitivity in the Malditor. You can read about it. So you can get your direct result on the same day or less than the time you would have waited for this. You can also do identification with other molecular methods. But if you don't have these systems, you can still go through the processes we discussed over the days. You inoculate on your primary plates, you do your identification when it has grown, and then your gram is directing you. Then you do your AST when applicable. Okay. Then the results, like I said, will have to go to the physician as a 48-hour results based on when you got it, or when there's no bacterial growth and they come, you give them no bacterial growth after 48 hours. Some hospitals have a system where it is mandatory to always enter in a 48-hour results. If there's bacillus contaminant, you report as such. If it is Staph epidermidis, you report as such. Candida species, you report as such. If after the 5 days, there's no bacterial growth, the machine itself will give you a negative alarm, and you go out and bring out your bottles as negative. And you report to the physician as no bacterial growth after 5 days. So we can see the advantage of the Bactec system over the manual blood culture system, where we can go 5 days instead of the 7 days. But still, some hospitals keep their systems at 7 days. So it is up to the institution and what. But for 5 days, it has been controlled that you can get recovery for most of the bacteria that will cause infections in the blood, with the exceptions of the ones we spoke about that you have to incubate for a longer time. So pathogenic isolates also will have to be reported with their antimicrobial pattern. All right. So sometimes our hospitals have challenges in getting all the different kinds of bottles like you. We have PDs, we have anaerobic, we have aerobic, we have mycotic, several. And we were talking about the costs involved in setting up microbiology lab. So you do with what you have and you rise gradually. So this is a study that was done in 2015, comparing the BACTEC for pedics with the BACTEC with the adult aerobic. And they realized that there was no significant difference in the results or in detecting bacteremia from using the pedics and the adults. So what they did was they tested pedics with pedics bottle and adult bottle, and there was no difference in the results. So if you don't have the pedics, you can still go ahead and use the adults. But if you have the luxury of getting them, you can go ahead and get them. All right. And I also wanted to put out this study that's maybe will answer why we get a lot of low positivity rates in our blood culture. When you go into your books and then you count the blood cultures you did in a year, and then you look at the positive cases, you realize that they are not that much. And like, let's say myself, I work in a teaching hospital where it's a referral center. So, I mean, we should be seeing positive cases, but it's not so. So this study was saying that variables like the volume of the blood and the number of bottles collected play a significant role in getting a positive outcome. And it said that 80% of samples or patients who were negative to single blood cultures were found to be more than 90% positive when they used two cultures. I don't know if I'm making myself clear. So they did single bottle cultures for a group of patients. Now, among the same group of patients, 80% of them, when they did the double, were showing positivity. So this goes to reiterate the fact that the double sets is very important in recovering positive blood cultures. But like we were saying, once again, cost. It means that one patient, if there's no subsidy, will be paying almost 800 Ghana cedis for a good blood culture to be done. All right. So with this, we move on to stool culture. So we do this to detect the presence of pathogens in the GIT. Usually they cause dysentery, enteric fever, diarrhea, which are shown by signs of mucoid, bloody, white water stool, abdominal pain, nausea, vomiting. So this sample is easily collected in majority of the patients, but we want a fresh stool sample. Whether it is for RE or whether it is for CS, we require a fresh stool sample. And this sample is ideally 2 sets at subsequent times. So one sample is not enough to rule out GIT because of the way the shedding, how they are shed. So it is best to take multiple samples on different days, but not too much interval to be able to get a positive stool culture. And once the sample is taken, it should be cultured as soon as possible. In fact, recovery of some of these isolates requires that the stool should still be warm. Okay, we said when we were doing media preparation, we said that temperature affects pH. So once the temperature of the stool starts dropping, the pH will start rising. And then some of these organisms that would like to grow in alkaline may not grow well. So we should watch that. Now, how do you say a sample is inappropriate? If your sample comes hard and dry, not formed, hard and dry, or you can see urine in the sample. You can see soap, because some patients just want to portray some level of neatness. So they may end up contaminating their stool with soap when the container is leaking, or when you see evidence of a fixative in the stool sample. It is not appropriate. Now, for the materials and equipment we need, the major ones, the microscope, incubator, hot LV, Benson burner. And for the media, for Salmonella or Shigella, we can either use XLD or DCA or SSA or McConkie for the culture. We can also use for other pathogens, TCBS, alkaline peptone water. For identification, we need urea, citrate, TSI, we need selenite fecal broth. Very important when it comes to culturing of stool. We need the antibiotics, you need your stains. For this place, we need antisera for typing the Salmonella or Shigella. And then we need your pasta pipettes, slides, cover slips, and all the other miscellaneous things that will help you. So for stool culture, for Salmonella or Shigella, like we said, you can either use XLD, DCA, SSA, or McConkie. So you have to look at the macroscopic appearance of the stool. You are looking out for places with blood or mucoid, or evidence of blood or mucus in the stool, which you have to report in your macroscopic, and then ideally pick from those areas. But here, about 1 gram of the stool is placed in salinite fecal broth. And at the same time, a loopful is inoculated onto the chosen media, and all is incubated. Now, the salinite fecal broth is selective. It is also, it suppresses the growth of, or inhibits the growth of a lot of the Enterobacteriaceae we don't want to see in our stool culture, and allow the Salmonella or the Shigella to grow. And the inhibitory substances in the SF broth starts waning off or starts reducing within 6 to 12 hours. So if you leave your SF broth just like your primary plates, you will defeat the purpose. It is not bacteriocytic, it is bacteriostatic. So after 6 to 12 hours, if the inhibitory elements start to stop working, the bacteria that you suppressed will start growing again, and then you defeat the purpose of using the SF. So please, let's take note to work on it within 6 to 12 hours of incubation. So when you come the following day, you read your primary plates, and then you subculture your SF onto another plate. So for Salmonella Shigella, we are looking for non-lactose fermenters that are indicative of these two organisms. So on a McConkie or on a DCA, XLD, you see them as pale or colorless. They usually have the color of the medium, and sometimes you can see blackening in there. So those isolates can be picked. You pick those pale or non-lactose fermenters, and then you go ahead and you do the appropriate identification test. So you put in your urea, and once your urea turns positive in 4 hours' time, you just stop the test. But once it is negative, you go ahead with your incubation of the other biochemical tests, and then you do your sensitivity when you're able to identify that it is Salmonella or Shigella. And then you do your AST as well. Now you report the stool samples as either no Salmonella or Shigella isolated when there was growth, but then it was not what you were looking for. And sometimes, in a strange way, there will just be no bacterial growth. Okay, so that one to report it as no bacterial growth. So for the positive cases, you report alongside with the AST reports. And if you want to culture Vibrio cholerae, it is ideal to use TTBS for the culture. So in the stool, you see a lot of mucus and flecks. Mucus flecks in the stool, and it is usually described as rice water stool. And we know that it is seasonal. So when it peaks in the rainy seasons like this, when there's flooding and there's planking from the sea into the environment, you can get Vibrio cholerae going up. So we can do microscopy in several ways. You can either gram, and you see gram-negative short, curved, or comma-shaped rods. And then you can do the hanging drop test, where you put paraffin wax on a slide, and then you put a drop of your inoculum onto a cover slip. You invert the slide on the cover slip, and then you turn it. So the drop will be hanging from the cover slip, and then you see the shooting star or dart, rapid dart motility of the Vibrio cholerae. And then if there's the provision for dark field microscopy, you can also see them as well. So you can enrich your stool sample in alkaline peptide water, and rapidly grow. You see a thick white pellet on the top of the broth, and then you culture in your TCBS. So, and you'll see them as yellow colonies here, like you see here. There are other, so usually we don't follow, we are like, oh, only NLF, but there are other pathogenic E. coli strains that could cause infection in several, both adults and infants. So these strains are named according to the mechanism of their symptoms. So we have enteropathogenic E. coli, and it usually causes mucus diarrhea and bloody diarrhea. And then there's ETEC, enterotoxigenic E. coli. This is what's called the traveler's diarrhea. And then it has no blood in the stool. There is no blood in the stool, but the stool is watery. Then we have the enteroinvasive E. coli. There's also cramps, vomiting, chills. And then we have the enterohemorrhagic E. coli. So that one is also bloody stool. So these are E. coli strains that can cause infection. And usually we overlook this. So maybe some hospitals will have a protocol that, okay, infants under 2 years or infants under 5 years, we will screen for EPEC or ETEC, and then they will have the antisera. So if you want to screen for these, instead of going in for the non-lactose fermenters, you go ahead and pick the lactose fermenters, which are usually pink, rose pink on the McConkey IGA or on the XLD, on the DCA. And then you do your appropriate biochemical test to identify E. coli. So if you have E. coli, then you can go ahead and use the appropriate antisera, if available, to type or to screen for the various strains that are available. So this can also be done on stool culture. Then there are other pathogens as well, Campylobacter jejunum and H. pylori, which can all be cultivated from stool. But usually their cultivation or their growth is a bit difficult. C. jejuni grows at 42 degrees Celsius, and it can take like 2 to 5 days to grow. But so usually molecular methods of identifying them are used, or Almighty Gram can identify it. This one has a peculiar seagull wing. It's like the when a bird opens its wing, and that particular bird is called seagull. So it's the seagull shape, gram-negative seagull wing. And usually when you are staining for this, the saffroning or the final stain doesn't work. So usually it is advised to use carboxyfusin to do the final staining for the Campylobacter. It also has that darting motility, so you can check it from the hanging drop. But this is usually when you have after culturing it. So it's difficult. Molecular wins the day when it comes to this place. H. pylori as well. It takes about 3 to 8 days to grow, but it can be cultured on CA, SBA, and then you can enrich the medium with brain heart efficient broth before you work on it. But serology can also help in identifying them. So these are what is usually used for the identification. I saw this and I wanted to share. So it's been a long time. XLD is almost lost in the system, but several studies have shown its superiority over McConkey, over DCA. So if we can, let us get the XLD. This study showed that XLD was very effective in isolating 39 out of 69 positive samples. They took these samples from, I think, poultry. Yeah, so it got 55%, and then 59%, 56%, sorry, whilst SSA was just 42%. So if we can, almost half, if we can go in for the XLD, it will be better. That is to managers of laboratories who are on the feed, or you can recommend to your the head of your lab about that. So we are off to our final session, which is talking about swabs. So there are several swabs that comes to the lab for culture. We can have eye, ear, the urethral swab, cervical swab, cord, nasal swab, rectal swab, and all these are coming from specified sites of the human body. And they all have a purpose for bringing them. The fact that they are all swabs doesn't mean we treat them all the same. Okay, so what you have to do as a lab scientist or as a microbiologist is you have to know every site this sample is coming from. First, find out whether it is a sterile site or a non-sterile site. So if it's a sterile site, it means that anything you see there, you should. Okay. So if it's a non-sterile site, you have to know the pathogens there and know the commensals or the normal flora there. This will save your day. So you have a chart, sterile site, non-sterile site. All sterile sites, I'm expecting nothing. So anything I grow, I am alarmed unless it's taken across the skin barrier. But for the non-sterile sites, I have the task of knowing the pathogens there and then the normal flora there. So that if I go and I grow the normal flora, I don't get excited and say, hey, I've grown something, I'm going to find drugs for it. You may be killing someone. So for ear, I wanted to add the comments out, but the table was just getting too long. So let's do with this. For ear, some of the common pathogens we can culture is Staph aureus or Pseudomonas aeruginosa. For the eye, we can get Staph aureus, H. influenza, Neisseria gonorrhea. This is often seen in children. It's called ophthalmia gonorrhea or something. So this is when a woman has gonorrhea, is giving birth, the baby picks up the gonorrhea through the eyes and comes out, and then the eyes are virtually closed or plaqued with pus. So you can get an eye sample for where you grow gonorrhea. We can get chlamydia and can get other gram-negative growths. In the vagina, we can get gonorrhea, candida, chlamydia, Gardnerella vaginalis. You can get strep pyogenes, agalactia, it should be small a. Can get T. vaginalis, T. pallidum there. On the wound is usually taken somewhere across the skin barrier or deep-seated wound. So you can have Staph aureus, strep pneumo, H. influenza, all these can be grown there. You can have gonorrhea. And the reason for knowing this is to help you in the selection of your plates. Okay, so if you know that this site, I hardly grow gram-negative rods, there's no need to add a McConkey plate, okay? Because McConkey will just differentiate your gram negatives from your gram positives. So if you know in my eye samples, I hardly grow gram negative rods, I can, in a way of making gains for my lab, take out McConkey. So knowing the sample sites, knowing what you're going to grow there will inform the choice of media you use. So we say we can get urethral smear, we can get gonorrhea from urethral smear. We need to add chocolate agar or gonococcus chocolate agar or any specialized like thiamartin to grow the gonorrhea. Okay, you don't have to use McConkey for urethral smear unless the diagnosis is saying maybe there's a wound, there's a catheter put in there and there's a wound, and the diagnosis the doctor gave you is suggested of that, then you can add a gram negative to try and differentiate. You can add McConkey to differentiate a gram negative rod. So samples collected, most of the swabs, in fact, all the swabs are not collected by lab scientists. And my fellow lab scientists, I used to work in a lab where we would take HVS, and it was so uncomfortable for the patient because we didn't have the bed that would give the lithotomy position. And so the sampling will be bad, and a poor sampling will mean a poor result. So please, let us do the right thing. I think the nurses are trained. If they are not trained, or if we go for our unit meetings and we have interactions with them, let's find out how the samples are collected. HVS should be taken with a speculum, and it should not be taken by the patient herself. It should be taken by a trained nursing professional, a trained doctor, or if the lab scientist is trained and has the appropriate equipment, speculum, and the bed, they can go ahead and take the HVS. Wound samples are also not taken by lab scientists. It is usually taken on the wards or at the dressing areas. And if the patient comes and the wound is opened, the sample is taken before the dressing is done. So, and the ear sample, eye samples, all these are taken by trained health workers. These samples are to be transported to the lab as soon as possible. Like we have been stating that some of the organisms are sensitive to cold. So when you put it in the fridge, you may lose them before they get to the lab. All right. So once the sample gets to the lab, you sort it out, you give it a number, and then you start processing it. Like we said, you don't have to refrigerate it. So I tried to do a combo of all not all, I just spoke about a few of the swabs, and let's see how it goes through. So this is the direction from here down. So your swab comes to the lab. This is an HVS. You have to do your saline wet prep, and you do your gram. Usually, ideally, swabs should come two for the culture. So you have one for the routine examination and the gram, and then you have one for the culture. So if you have one for the RE, you do your wet preparation, and then you do your gram staining. If you have just one for the culture, you make sure you culture the swab before you add saline to it. But if you have two swabs, you can use the first one for RE and then the other one for the culture. So for the RE, we are looking for parasite CV, or we are looking for, if you can see, candida cells, whether you will see flu cells, which are indicative of Gardnerella vaginalis, and then any other cells that will be helping diagnosis, your white cells, and then the gram, you are looking out for GNID. But like I said, usually HVS, because there's a lot of epithelial cells sloughing there, often they could mask the GNID, making it difficult to see. But if it is truly there, you see them. And then you go ahead and inoculate your sheep blood agar and chocolate agar. And there is no McConkey here because in HVS, if we go back to the chart here, whatever we are looking for, we hardly have gram-negative rods. If you can see, there are hardly any gram-negative rods here. So there's no need for McConkey. So BACA, it will support your strep agalactia, your strep pyogenes, it will support your candida, and then you are good to go. If there's a growth, you do the appropriate tests, but identification test, and then your AST. So in HVS, just a few, like we have mentioned at the top, you don't go following gram-negative rods in the HVS because there can be contamination from the anal orifice. Unless you have a pure growth of gram-negative rods growing with a high white cell with a good diagnosis, let's say incomplete abortion or traumatic something, then you can go ahead. But usually we're looking for our gonorrhea, our strep agalactia, our strep pyogenes, our candida, and then we are good to go. For wounds, there are lots of gram-negative rods in wounds. So we have our blood agar and our McConkey agar. So you culture, you inoculate, and then you gram. You put it on a culture and plate, and then you gram. And then wound, let's say you have a wound, diagnosis osteomyelitis. You can get AFBs in the wound. You can see it when you prepare a smear, but you can't culture it in the lab. So you do your Z10 smear as well, based on the diagnosis you have. You choose your sheep blood agar or McConkey agar, and then you culture, you incubate. If there's any growth desired, you do the appropriate biochemical tests, and then you are good to go. Then for eye as well, you do your you inoculate your media, and then you gram and follow as well. Ear swab, you follow as well. You do your plating, and then you gram. I think my plating should have come before my microscopy. Yes. All right. So this is just a few points I want to bring out. When you get a swab, so let's say you have a swab from an eye swab, and you are inoculating it on the plates. Make sure you roll the entire tip of the swab, because sometimes the swab comes, there's no color. You just see that it has been used, but then you don't know where exactly. So make sure that every part of the swab, I don't know how to show, but you just roll it, roll it round. Not only one part, don't just use one part. Because if you're using here, what if the pathogen is at the other side? So roll it on the plates. And please, when you have different plates to inoculate, this is how you go about it. You start from the enriched to the less, or the more nutritious to the less nutritious plates. Okay, the more nutritious to the less nutritious. So if you have a chromogenic agar, you can start with that because it is very sensitive and specific. Let's say you have BACA McConkey to plates. Always plate the CA first. And then you follow by plating the blood agar and then the McConkey agar. So let's say you have an eye swab or something. This McConkey does not support Staph aureus. That has Staph aureus. And the swab, the sample is just at this place. So if you place McConkey and then you just roll the whole thing there, and you have, let's say you have sparse number of the pathogen on the swab, you roll it here first before you come to the BA and roll. You may end up losing all the Staph aureus here. And then you come here with an empty swab, unknowingly to you. So you will incubate, and then you come and say there's no bacteria good, but there's bacteria. But you lost the bacteria on the McConkey, right? You lost the bacteria on the McConkey because it won't support the Staph. So please, anytime you have several places to inoculate, you start with the most nutritious or the most enriched and end with the least enriched. Okay. Now the streaking is same here. For the stool, for the swab, you use your quadrants, that's the four area or 4 dimensions tricky. If you want to use half and try and do 3 on the half of the plates. All right. Now, most of the swabs, like I said, are taken across the skin barrier. So like I've always been saying, you always have to rule out pathogens or contaminants from the skin that will get into your sample. So if you are working on HVS, let's say HVS, and you know lactobacilli is normal, then you grow lactobacilli. You don't go ahead and report to the doctor, I have grown lactobacilli, So always rule out the commensal for the normal flora that can contaminate your sample, and then report what is truly there. So for this one too, in critical cases, you can give out the gram reaction. For the wounds, for the eye, for the ear, you can give out the gram reaction. Okay, so this quality control is for all the 3 that we have done. And because there's an equipment here, the automated blood culture system, we should adhere to the routine quality assurance and quality control processes of the machines. Some of the backtech machines, every day you have to print something, every day you have to check something and print out and document. So you have to stick to it, the routine, the daily, the weekly, the monthly, so that the equipment will work as it is supposed to work. You always set controls for your tests with ATCC strains. You document this in a log book, and then you keep your specimen until the result is ready and dispatched. You stock your isolates, and then your waste should be segregated well. Now, for safety, we have said it so many times in all the 5 or 4 days of our talk, and we should adhere to it. I was telling some of my people at work that, you know, in our labs, we have on the door, don't touch the doorknob with your gloved hand. Don't touch the doorknob with the gloved hand. But then once in a while, you see people doing it. So when I was in the lab, when I close and I'm going home, I wash my hands. And then, because I don't want to touch the doorknob because I am going home, I stretch out and touch the tip of the door. Because in my mind, no one will go and hold or open the door from that place. So I stretch out and touch the tip of the door to open and go home. Only for me to one day see a student who was in gloves also saying, well, they said don't touch the doorknob. So he also stretched and touched where I have been thinking that it was safe with his gloved hand to open the door. And I was like, oh my God. So my safe haven is someone's backyard. So safety is paramount in the lab. Let us wear our gloves. Let us keep to the rules that we have put in the lab, the do's and the don'ts. Let us keep to them, segregate our waste well, be cautious of the organisms we work with. And I'll use myself once again. Many years, I was working in the lab, and I was on the stool bench, and there was this isolate I was looking at. It was gram positive. It was large rods. I could see large rods. And I was thinking that, oh, this one, when I placed it, it's going to be gram positive because the rods were very large in the wet preparation. I was in there. And then I don't know what happened. I think I went to eat in the evening. I had a very serious stomach upset, very terrible one, that I had to be taken to Lekma Hospital around 12 midnight, late in the night. And when I went, I was so sorry for myself. I told the lab scientist that I want to look at what is in the stool, only for me to go and see the same thing that I was working on in the daytime in my stool. So we have to take notes. Safety is very expensive. So in the lab, we should take notes of our environment and keep up the appropriate measures to protect ourselves. So I want to say a big thank you. I'm very happy for this time, and I believe these 5 days have been very influential to all of us. Thank you, and over to you, Dr. Edujesi and Dr. Kwashi.
Thank you very much, Dr. Okai, and it's been another insightful presentation. GS, are you around?
Now come around. Can we continue?
All right, thank you. So, colleagues, I think we've had another insightful presentation, and we want to discuss what has happened over the period. So, if you have a question, you can raise your hand. But in the meantime, I'll also try and go through some of the questions that we may have in the chat. So let me take some of these ones. Augustine Owusu Ahin ask, should we reject HVS samples taken from a woman who is menstruating? Dr. Okai.
Sorry, I was muted. So you can work on it, and if the sample is inappropriate for you, you can ask for repeat when the cycle is over. Thank you.
All right. Namuka Banetiasenuhu. I'm not too sure your question, but you are asking whether you have to use the same swab to go through all plates. Is it in the case of HVS? So you may want to clarify, but Doc, I don't know if you, in case you take the swabs,
for an
do you
eye
use
swab,
the same swab to plates?
Yes, you use the same swab. You use the same swab for the culture plates. So if it's an eye swab, you go to your several plates. They hardly bring two swabs. If you get two swabs, it could be from maybe a left eye and a right eye, or left ear and right ear. So you use one swab through all the plates. That is why you have to start with the most nutritious media to the least. Thank you.
All right. Thank you very much. When a positive vial from Bactec is plated and it comes out as no growth, what do you do next? This is the question coming from Fred.
You put it back in the Bactec machine.
Okay.
Usually you put it back in the Bactec machine. If it still comes positive, you plate it again. If it is still negative, you let it go as no bacterial growth. But then you let your gram direct you. Because sometimes the plate may not be recovering the isolates, but then it is there in the gram. And then if it's happening very often, please you check your control so you get service for your equipment.
All right. Thank you very much. Antri Diana is asking, please, Doc, does it mean Makonke agar can't be used on gram-negative bacteria?
I don't think I have said anything like that.
Probably it's just about the differentiation that you had mentioned that Makonke can be used
for Makonke for gram-negatives. I haven't said. I don't think it came out. Maybe it was informed by something.
Oh, look.
All right. Thank you.
Yeah, look.
Yeah, hello.
Yeah, I think the questioner was trying to find out, I mean, based on the order of plating, that's how come the questioner was asking that question.
Oh, okay.
And that one
But
actually, I
Makonke
think
is
it
not
came up in one of,
restricted to.
yes, I think it came up in one of our previous discussions where we were looking at how it suppresses the growth of gram-positive organisms. Just like Esther was saying, if you go and, rub your swab on it the first time, and assuming you have a wound specimen, and your isolate is supposed to be gram-positive organisms such as maybe strep or staph, then there's a possibility that you might lose it before you actually even move on to your other your other plates, the rich media such as the BA, and for that matter, you may record a false no bacterial growth, which ideally it's not good for your patient.
So I think that's why the person was asking that question. But it can be used. It can be used for gram negatives. And ideally, that is what even helps us in the differentiation as well. Thank you.
All right. Okay, so Sokoli wisdom, I think you are just asking about appropriately taking the HVS and the use of the speculum. Yeah, so you may want to look at whether you are doing HVS or vaginal swab. Are you dealing with the cervix? So please, let's get the appropriate process and you collect the appropriate sample. So Mavis Esinu Dogbache, I think Doug mentioned the HVS, and in the case of a menstruating woman, go ahead, do it, and just make observations to investigate if you want the sample to be retaken when the woman is not menstruating. Please, will it be advisable to use CLED to culture HVS? Yes, swab, since it supports the growth of both gram-negative and gram-positive bacteria. Samuel Esa is asking.
Yes, you can substitute McConkey with CLED. Yes, you can.
Thank you. Please, what's the standard way to report HVSRE, especially the gram reaction, taking into consideration the lactobacilli as normal flora? So, Doc, this has come up over the period we have had these presentations, and I still maintain some of you experience one together with a professional body should come up with standards of reporting, and I think it will be very useful for all practitioners. So, Richard, this is something that will be worked out. I don't think she just saying it right now will solve the problem. It's come up over and over, and the professional body will have to look at it with the experts and come up with a standard reporting template that all of us can use. Okay. Okay, so I think now I can take some raised hands. Maxwell Tete, can you ask your question?
Good evening once again. I want to thank Dr. Okai very much. Some of us like the way she presented, and her slides are so informative. So we want to ask, is there any way she can give out her email so that when those of us who are interested, we can request through her email or through her contact? That's all that I have, please.
So the slides are going to be shared, and I believe Dr. Okai's contact will be available for people to contact her for further explanations when necessary.
And please, to add to that, by which means are they going to be shared? We want to know. Since some of us are not in the pages where maybe the WhatsApp pages where the slides will be posted on. That is why I asked that question.
There was a registration for the CPD, and I want to believe contacts were collected. That will be used. But of course, if these are put, say, on a drive, they'll be available to the regional leadership and shared over. But please,
Okay.
at this point, it's important we are all part of platforms where information are shared. Now, the WhatsApp platform can take more than even 500 participants. So I will encourage you to be part of the professional platforms.
Okay.
That will be very useful for all of us.
Okay. I'm on some. I don't know which ones it to be shared on.
Then you don't have a problem. Wherever you saw the link to join, it means that you will still see where to download the presentations.
Okay. I'm grateful, sir. Thank you.
You are welcome. Yeah, any more questions from any of us? Aaron is asking, if suspecting a fastidious organism, if you are to choose between chocolate agar and blood agar, which of them would be appropriate?
It was from which specimen, please? What organism in particular?
So, Amos, you may want to come again to clarify the question or put it in the chat. Aaron. But before that, I think there is this. Please, in case you are taking a neonate sample for CS and you are not able to get the 2 to 3 mils, if you have about 0.5 or a mil, can you continue with the rest? I think yes. If a bird in hand is worth twice in the bush. So that one, I wouldn't let dog answer. If you can get more, go for it. Else, whatever is available, kindly work with it. Okay. So, Doc, we are not getting any more questions. And I want to switch over and check the YouTube platforms and see if there are some questions coming in then. All right, maybe I have a couple of questions on the YouTube page, so maybe let me quickly run through them.
Okay, Doc. Doc.
Yeah, I'll come to you, please.
I just want to respond to a question.
Please. Once I've switched over to the YouTube, let me just read through. Then once we come back to the Zoom, I'll please take it up. Okay, so Eura Ajua, please, what are some of the microbiology tests that you recommend for a health center?
A startup lab. Is it a new lab?
So a health center.
Health center, you can do urine culture, you can do your grams, your stainings, can do urines too. But a health center, you can start with your grams and then at least your urine.
Okay, I agree to that as well. So at least have the platform to do your gram. That means your microscope, which is already in place, then you can get your gram stains and the Benson burner cylinder. Then if your traction is built up, you can start doing the cultures. Okay. So please, will it be advisable when taking HVS while the patient, this thing seems to come up. Menstruating. Is it a common thing that people are experiencing? If it's not urgent and pressing, at least the 340 can be allowed to go over.
Recently, I think it's on the rise. I've seen a couple of cases, but I mean, if should come to shove and the person is really suffering, you have no option than to take the sample. And then, as Esther said, you wait for the period to, vamoose, and then you repeat again because it's becoming plenty, especially with the coming in with a lot of myomectomies and hysterectomies here and there. A lot of patients are actually being asked to do it, and they are having a lot of discomfort. So when they come, you can't really turn them away.
Okay. Yeah, but if possible, you want to avoid any obscurity, so
exactly
you can take it when, because most menstrual period are up to 4 or 5 days. So if you can really do it at when you can see clearly and give the best of output without doubt,
that's the most
I think
ideal.
it's more useful. Yeah. All right. So those are the ones on YouTube too, and I seem not to have any hands raised, and there are no questions in the chat. So Michael, I think you can add what you wanted to add.
For now, I don't really have much to say, but I think we shared a link where individuals that need support could reach out, and I've seen a lot of responses coming through. So in the coming days, we'll try and tease out the data, and then we'll reach out to all the facilities. In the meantime, Esther's contact will also be given out. So please, you can reach out to her, any support at all, whether it's for a startup, as a lot of people are asking for, whether you are already set up and then you need some bit of training or polish up, that's also fine. So we are really grateful, and I can see the ratings. I mean, on the average, Esther is on the 5-star level at the moment. So I think it's really gone down with the group. And then we look forward to making sure that at the end of the day, bacteriology is experienced across the length and breadth of the country. Thank you so much. I don't have any additional information to give. Thank you.
I think, thank you too for the support and help. So maybe the last one I got, what is the reason for safranin not being effective on Campylobacter during gram staining? Augustine is asking. Antwi Godwin, yeah.
Oh.
Dr. Okan, did you pick the question?
Yeah. Okay. So it is to do with the wall, the cell wall components of the bacteria.
Okay. All right. So Augustine Owusu-Ahin, I think you are rather making an assertion that vaginal infections is very common among young ladies around the coastal regions of Ghana. What can be the cause? This one, you have to share the data, then people can review and come to agree with you. And then it can be investigated further. So concerning the sample volume for blood CS using manual methods, is a 2 to 3 mils in 18 mil BHI for adults and children. Samdo is asking.
So for the blood culture, I was saying yesterday that there was a bigger bottle in the system that would take 45 mils of the broth to 5 mils of blood. But one thing you have to take notes with in the manual blood culture is the more the volume of blood, you cannot dilute out any inhibitory substances. So if you exceed the volume recommended and there are any inhibitory substances, it's a bit difficult to dilute them out. So you stick to the 45 broth and then 5 mils of blood for the adults, and then the 18 mils broth, and then 1 to 2 mils in the children. Thank you.
Okay, thank you very much. All right, so I seem not to get anything further, and I will personally want to add my voice and say that Dr. Okan, your support has been very great, and the presentations you have given have been very educative. I know this has started something that we will all keep to it, bring other experts on board. But my plea is, let's use our expertise to get some guidelines, some protocols that professionally can be established for others to use now and beyond. So GS, if you can take over and possibly close the session for today.
All right, thank you, PRO. I think there's one hand up. If we can give opportunity to him, Maxwell Tete.
Maxwell has already spoken.
He spoke. It's just that Nathan Odame has come up, so maybe he can ask a question.
Okay, thank you, Doug. About the bottle, the blood culture bottle. For me, I'm using a bottle which is not the bigger one. So how can I get the 45 mils broth?
Are you talking of a commercial blood culture bottle or BHI?
BHI.
So you want a bigger one?
No, the one I'm using now is not the bigger one. And here's the case, I'm supposed to take the 45 mils of the BHI against the 5 mils of the blood. So I'm confused. I don't know how to get that 45 mils of the blood.
Stick to the 2 mils to the 18 mils, 2 to 18. That is what you have. Stick to it.
Okay, for both adults and PDs.
Yes, yes.
Okay.
But don't exceed it. Don't exceed.
Okay.
Hello. Hello.
Hello.
Yes. Hello.
Hello.
Yes.
Doctor,
Thank you very much.
Can I go ahead? Hello.
Yeah, Lord, please you can go on. We can hear you.
The question I wanted to ask the one who just placed his question is that what's the volume of the bottle he's using, and that will inform how much volume of the brain heart infusion blood that he has to put in. So if we know the volume, then he can do the 1 in 10 dilution. That is, you take 1 part of your this and then to 9 parts of your brain heart infusion, and then you can work it out if you want to use that type of bottle you say you have. So it depends on the type of bottle you are using. Then you can go ahead with the volume of blood that you can add to it. So if you know the volume of the tube you are using, you can then decide how much blood should be put in if they can take the necessary volumes of blood that it's required. Thank you.
Dr. Dennis, over to you. Hello, Dr. Dennis.
Yeah.
Okay.
I
please
thought
over
GS
to you.
is closing
Yeah.
up, but I don't know.
Okay.
Say to Ajewa or
Hello, there's another issue somebody
Yes.
also raised. Sorry, there's another issue somebody raised as to which of the enriched medium he or she should use, depending on the fastidious organism that he has. So if you are dealing with a strep pneumo organism, then you have to use blood agar plate, because that one will demonstrate it properly. If you are looking at for Neisseria, meningitis, or gonorrhea, then you can use a chocolate agar plate. And then for our H influenza, you can use both the CA and then the BA to help you recover them well. Thank you.
Thank you, Doc. Dr. Kwashi.
say to Ajewa Teresa, your hand is up.
Yeah, yes, please. Thank you so much for the opportunity. What I would say is, Mama Esther and our leaders, God bless you so much for this wonderful training. This has been my problem. I please want to ask, the reuse of slides in the lab, it's not always helpful, but it's like they are always forced to be used by some of our in charges. So I want to know this from these studies, whether it is allowed or it is good for us to be reusing the slides. Thank you.
Hello. So I think this one, I don't get it when you say you are being forced to reuse. That they can't get slides to buy.
Slides to buy, and the cost of it.
No.
So we should always wash them, dry, and use it again.
For which test? Maybe if you are, say, urine RE, stool RE, possibly
Yes.
I may say that if there are people they have dedicated to kind of help you wash, you prepare the necessary decontaminating solutions and everything, that's fine. But there are some slides that you don't have to reuse at all. And how much is it that the 50 pieces of frosted slice or the plain slice for somebody to say that it's expensive and you have to reuse? Please stick to the necessary safety precautions and don't let people force you. You understand? Where you think it can be done and there are protocols to guide the safe use of that, no problem. But people shouldn't force you to do things that will not end up helping and even protecting you yourself. There are people who work and at the end of the day, they come up with all sort of infections and you'll be said to go home and sit there. You understand? So please, some of these things, don't take it as a professional.
Okay. Thank you so much, Doctor. I'm grateful.
All right.
All right, so on that note, we will introduce our next session. So next week, we'll be looking at biorisk and biosafety, and we'll end up with ethics and conduct of our profession. And so tomorrow and Sunday, we'll be on break, but Monday at the same time, we'll come back. We are encouraged by our participation and both on Zoom and on YouTube, and we encourage ourselves to go back, review the presentations on YouTube, and share with other people and ask them to subscribe. We want to also say a big thank you to the National Executive Council, all those who supported the training coordinator, the PRO. He has been very instrumental, and the team of people at the background ensuring that the program is successful, including our office staff. Thank you, and we'll meet next week, Monday. Doc, if you have any final words.
Okay, thank you, Dr. Kwashi. So I want to say that let's work with what we have heard over the week. Let's not forget, like Dr. Kwashi is saying, let's visit the YouTube pages and then listen to the lessons and apply them at work. Let's try something small and start up and rise, and we'll be proud of ourselves. Thank you.
Piero, do you have anything to add?
Yeah, please, what of the Telegram page in case somebody is not able to access the YouTube page? Thank you.
I think the PR team have been able to spread this wide. You can even see it on Facebook on our Gamls platform, Gamls TV. The presentation is always available. It has been published there, so you can review it at any time.
I couldn't see it also. Okay, I will look for it.
All right. So if you just go type Gamls TV on YouTube, it will pop up and you subscribe to it. At any time there is any notification, it will alert you.
Okay. Thank you very much.
Welcome. Piero, any final words for us?
Yeah, I think I'm fine. We just want to encourage people to subscribe to the page. So far, I think for the start of this, we were at 291, and now the count is around 771. That's a very good indication that a lot of our people are following up. The Twitter page too is there. So let's keep the pages busy and interactive.
So what I will also throw up to the team that presented this week is that we have given knowledge to people. We've asked them to go and practice. They would face challenges. So we may have to do something like a mop-up or a refresher if there's a need to be, where people want to share their challenges. So would look at the way forward after this week's presentation and see what can be done. If there's a need to collect some information and support people, how we can do that. So we'll get back to you on that. Thank you very much. So on that note, we say a big thank you to everybody who presented, contributed in any way for the success of this week's program. And let's expect more interesting days ahead when we start next week, Monday. Thank you very much, and bye for now.
Bye.
Bye-bye. Hello to Edwin.
Hello, Agba.
Agba, see you, they worry. You don't worry too much.